Hi, everybody. This is Brenda Green with the Be Strong Group, and I'm so excited you're joining us for yet another Tuesday chat. Once again, for those who may be new listening to us, uh, we are the Be Strong Group. My husband and I founded this nonprofit in honor of our son, Braden, who has sickle cell disease. And we found it in order to help to spread awareness of sickle cell disease through advocacy, education, and empowerment. And one of the ways we wanted to do that is take an opportunity to just share information that we learn or and that we come across with all of our followers. And we understand there are those of you who are watching who are supporters who just stumbled across the page, who have sickle cell or who love someone with sickle cell disease. So we're so happy for your support. We're happy for you listening. Every time we come on, we want to have something to where we can share. And a lot of topics we discuss are not just for those with sickle cell disease, it can be applicable to many other people with chronic illnesses. But we appreciate you for listening to wanting to learn more about the disease, what the warriors face, what their families face, and how you can support even if you don't have the illness. So I am so excited about our next guest, our today's guest. And if you watched us over the past year or so, you notice that we've had representatives from Braden's care team here, where he gets care here in Columbia at Prisma Health Midland. So we're excited because his care team is supportive of him and looks over the his entire health. So just understand that again, that when we come and talk to you, it's for educational purposes only. So if you have any questions or any concerns about you or your child, please seek and talk to your primary care physician or your specialist for your child. But sit back and listen. If you have any questions, you could put it in the chat. If you're listening on Facebook or YouTube, put it in the comment section. And if you're listening on replay, also put your questions in the comments and I'll make sure our special guests answer your question afterwards. So without further delay, I am going to welcome and bring to the studio Dr. Horan. Hey, Dr. Horan,
Hi,
how are
can you hear
you?
me okay? Is the
I can hear
microphone
you.
working all right?
I can hear you very well. Thank you for joining us. Um, and I want everybody to know this is Dr. Horan. I'm going to let him explain more about, tell more about himself. But he's here locally in Columbia, South Carolina, Prisma Health, Midlands, and he's an orthopedic surgeon, pediatric orthopedic surgeon. But Dr. Horan, you can share more about yourself, and then we can get on to
Sure.
to
Sure, fine. Happy to be here, Brenda. Thank you for having us. I think it's great opportunity. I love these kind of things for patients, and I hope lots of people are listening so they can answer or ask questions that they may have. Be happy to answer anything you have
absolutely.
when we're done or during the process. But as we discussed, I do pediatric orthopedics. What that means, I take care of just children. So for us, that means basically children in high school and below, so under 18. And that includes any kind of orthopedic ailment they may have. It might be a finger fracture, it might be scoliosis, it might be an ankle sprain, or it might be some other more involved illness, such as our sickle cell patients, or it might be a neuromuscular problem like cerebral palsy. That's what we do. We do all of those things. It might be bone surgeries or joint surgeries or things to do with muscles. And we run the gamut. Sometimes it's just reassurance that we see a patient say, no, those legs are fine and the child will grow out of it. And other times we have to discuss doing a surgery on things. So it's nice because we see everything. And compare that to some of my adult partners who just do hand surgery or they just do, let's say, knee replacements. In our world, we still do everything just like the orthopedist used to do 50 years ago. They were trained to do everything. And nowadays, everybody gets so much more subspecialized. The pediatric world, we still see all of it.
Oh, wow.
And so one of the things that we see as we were discussing, the whole point that we're here, of course, sickle cell, We see a lot in South Carolina. And it's interesting because depending on where you are in the country, it can vary as to your experience with sickle cell patients. So that might be where, so for example, I trained in Kentucky for my residency. I did med school in Charleston at Medical University of South Carolina. I did my college at Clemson for undergrad and graduate school. And I was born up in New Jersey. So I've been to quite a number of places. And each of those places has a different incidence of patients with sickle cell. And so in Kentucky, for example, it's a mostly Caucasian population where we didn't run into a lot of sickle cell patients. And so as such, as a resident there, you might not really encounter a patient with sickle cell, either trait or the actual disease itself. You might be in a patient population that has a high percentage. So in South Carolina, we have a vastly larger number of patients with sickle cell, both trait and illness. And you have sickle cell clinics. So you have hematologists who specialize in that. And it varies with which part of the country you're in. So here we see a lot of it. Fortunately, for the most part, is most patients don't need to come to the orthopedist very regularly. We do have orthopedic ailments that go with the illness, and those things we do follow. And sometimes we have to see acute things that happen unexpectedly. And so it runs the full gamut for those kind of things that we see. For those who aren't as familiar, if you don't have a family member who have sickle cell, it's the basics is it's basically an abnormal shaped blood cell that causes some problems when it travels through the body. And so basically this sickle celled shape blood cell can get stuck or caught in tiny little capillaries. And when it does, it can create some problems. One of those things might be pain. So we see a lot of patients who have pain as a result of their illness. It might be an acute pain that comes out of the blue, and one day they come in and a joint is severely hurting, or a leg, or maybe their chest, or their ribs, or their back. Sometimes it's really severe. We call that a pain crisis or a pain episode, or a sickle cell crisis is another word that you might see. And that's where they have severe pain. And basically what it is the blood vessels supplying the blood to a certain part of the body basically get stopped up, and it causes the pain receptors in that area to go on fire. And they basically report that back to your brain as this excruciating pain. And so we see a lot of patients for that. For the most part, it's a medical treated illness at the time where hydration, oxygenation, the pain medication are the main treatments. But we get called a lot because x-rays are taken to look at the body part and say it's a knee or an ankle. And we'll often see some abnormal findings to the bone. And the reason is because over time, lots of those episodes can cause an issue with the blood supply to the bone. And so you'll hear this a lot with the words called avascular necrosis. What does that mean? So avascular, so that sounds kind of something with blood vessels. So avascular means a lack of blood supply, and necrosis kind of sounds like or it kind of means what it sounds like. It's basically that area can get necrotic or even die because of a lack of blood supply. Where we run into this is basically throughout the bones, we have blood that goes to them that keeps them growing and keeps them nourished in adults and kids. And if those blood vessels, their supply gets decreased, it's kind of like turning the water off to the vegetable garden is the way I think of it. And basically, if you like to grow vegetables or you're a gardener or you have a lawn, you water. If we don't water it and it doesn't get enough water to grow, then you can get a patch of maybe the tomatoes that you grow might not grow as well, or maybe they even die because they went in the heat of the summer with no water. Well, the bone can be the same way. So you can necrosis to a part of the bone where it gets basically withered and it can die. Now, bodies are dynamic and they want to create new bone there. So the analogy of using the garden would tell it, oh gosh, that tomato plant died, and you pull it up and maybe you plant a new one. Well, the body tries to fix that by maybe putting in new bone or try and repair it. So we'll see x-rays that we get called about of a patient who's got avascular necrosis of a certain body part. And we'll come take a look. And many times we just have to watch and observe that type of thing. And sometimes we have to treat it. And so basically the way that you treat it is, well, if we have bone that is misshapen, sometimes we have to do a surgery on that. So for example, in a hip, we have a kind of a ball and socket where you have a socket that fits inside, or a ball that fits inside of a socket. Well, if the ball part has necrosis, it may not be shaped in a normal round shape. It may kind of get a little egg shaped or even a little flattened out. And sometimes we have to do a surgery to try and improve the shape to make it work normally. Unfortunately, sometimes we run into very big problems where we have a lot of necrosis, and you might even hear about a patient who has to have a joint replacement because their bone is misshapen enough. And almost every sickle cell patient who has the illness has avascular necrosis to some degree. It's just a part of the process. Every bone can get it, and depending on how involved or how severe it is, they might need treatment for it with a surgery to help fix that area, or replace a part that doesn't work as well, or they may just need observation to follow it. Sometimes we use physical therapy, sometimes we use pain medications, and sometimes we just follow it with x-rays. The other thing that I think is really important to know about in the orthopedic world is the role of infections. And with patients who have the sickle cell illness, infections are a big deal. And you can get infections for a few reasons. One is most patients will have either had their spleen removed, or their spleen is what we call atretic, or it's sort of shriveled up and it doesn't work. And everybody says, well, what's the spleen do? Well, the spleen is a big help in your immune system. It basically helps clean out bacteria from the blood, and it helps make and store white blood cells. And so if you don't have a spleen, you have an increased risk of infections. You're kind of what we refer to as being immunocompromised. So the same way you might have a patient who is undergoing chemotherapy or a treatment with a medicine that reduces their immune system's ability to fight infections. So almost all sickle cell patients are in a way immunocompromised because they don't have the same infection fighting mechanisms that a patient who has a normal spleen does. So by having that, it makes you at risk of having infections. One of the bacteria that can cause an issue with that, specifically with patients with a different spleen function, is a bacteria called Salmonella. We all hear about that from food poisoning, right? You hear about Salmonella on maybe if you don't wash your hands after dealing with raw chicken. And you can get it from some other places too, which is really important for patients who are around sickle cell patients to be aware of. And so one of those areas that most people don't know about is in handling reptiles. And so you might have, young kids, and maybe you're allergic to cats or dogs, and you say, hey, what about we'll get a baby turtle because that's kind of cool, and we'll have it's maybe more fun than just a fish tank or something. Well, reptiles, especially baby reptiles, and specifically baby turtles, have Salmonella as part of their normal flora or their normal bacteria that they have on their skin. And when you're around Salmonella, and if you have the sickle cell syndrome, it makes you susceptible to getting an infection from that bacteria. And so ideally, your main physician or maybe your hematologist has brought that up and said, by the way, a pet that you guys should not consider would be a baby reptile or a lizard or a turtle, because it's just an increased risk of being around that bacteria. That doesn't mean you can't have one. You just have to be very specific about handling the animal and washing your hands thoroughly. The same way saying, well, there's no problem eating something like chicken. You just have to be careful handling raw chicken so we don't transmit that bacteria. And so you wouldn't think about that as a common thing, but we see it. And when we have a patient who comes in with an infection, that's part of the questions you ask the patient. By the way, have you had any exposure to reptiles? And it's for us, it's kind of a question you might get on a test when you're in training about a sickle cell patient with a hot swollen joint, and maybe the family just got a new baby turtle in the house. You say, I know the answer to that. It's going to be a Salmonella infection. But for us, we think about that, and for the average patient, they might not. So it's important to know. How do you get an infection? Well, that could be from just being exposed to bacteria and maybe even having a small scratch on the skin. Maybe there's a little mosquito bite that gets scratched. And when we do so, we might introduce bacteria into our bloodstream. And when we do, the body has trouble fighting off those bacteria in the same way that somebody who doesn't have an immunocompromised state does. And that's specific with sickle cell patients and the salmonella bacteria. That kind of bacteria is more prone to cause infection. The most common is the staph infection. And you hear about that a lot in everybody. But that's still the most common in all patients, but specifically the salmonella is something to be aware of and something all providers need to be cognizant of. Where that shows up would be a patient who comes in and they say, my gosh, my knee is really hurting. And it's really hot, it's red, it's swollen, and it hurts to bend. What's interesting is something that looks like an infection in a sickle cell patient looks exactly like a pain crisis in a sickle cell patient. So it's very hard to tell the difference. So we'll have a patient who comes into the hospital. They're admitted to maybe the hematology service because their knee is so painful and it's swollen and it's hot and red, and they have a fever. And all of those things are the same things we might see in a patient who doesn't have sickle cell. In the patient without sickle cell, we'll say, that's an infection. We have to go do an MRI. They might need a surgery to go wash the infection out. They need antibiotics. The difficult part on the doctor's side is in a sickle cell patient, that looks the exact same in a pain crisis. You might have a joint that's hot and red and swollen and hurts to walk on. And an MRI, which can show things that are swollen, it might show things that look like an abscess, can look the exact same in a patient undergoing a pain crisis. So it can be very difficult for us to try and figure out if that needs just antibiotics, pain medicine, or observation. And so we don't always know how to tell the difference. There's no magic bullet we have. There's no special test that we can order that says this one's an infection and this one's not. We'll do an MRI, and a avascular necrosis appearance can look just like an infection looks. So it makes it hard for us to figure that out. And so you might have a son or a daughter is admitted to the hospital, and the orthopedist may be called and will come in and say this exact thing. It can be hard to tell, but if it's not getting better with some antibiotics and observation, we'll often talk about doing something called a biopsy, which is where we might give the patient some sedation so they're asleep, and we might go stick a needle into that area to get a sample of the tissue or even the bone tissue to send it off to the lab and see if we can see any bacteria under the microscope. So in somebody who doesn't have an infection, we shouldn't see any bacteria there. If somebody's got an infection, we might see bacteria, and you shouldn't see bacteria in a bone or in a joint. So that's never normal. And if we do, then we try and grow that bacteria in the lab and identify which bacteria it is so we know which antibiotics to use. Sometimes we have to do a surgery for that to wash the area out and get rid of most of the bacteria and let the antibiotics get in there and do their job. And so that's not fun to have happen. And that's one of the things that is unfortunate with all the things that could have a result of having sickle cell. It's, boy, we've got an increased risk of avascular necrosis. We've got an increased risk of infection. And because of both of those, an increased need for surgical care to help with either of those things. And that's another something that you want to have a child go through, or an adult, but especially when it's your child, that can be really hard to watch, especially when this is something that happens regularly. And some patients have this happen more than others, and it can be very bothersome for the family. It can cause missed school time, can cause a lot of times that we're in the hospital for a week or two. Fortunately, the patients usually are really good troopers about this. So I like your word warriors, because that's exactly what they're like. We go see them. We often know exactly the patient who it is because we see them so often. So we'll walk in and say, oh, hey, Bobby's back. How's it feel this time? And a lot of times I can get that information from the patient, even if they're young. I say, well, how does this compare to the other times? And they'll say, well, this is just like last time. And that can help us sort of err towards the side of maybe observation, or they'll come in and say, boy, this is much worse. Something's different about that. And so We don't like to have to see it, but it definitely comes in quite often. And we're still working on trying to find that magic bullet, some way to do a special test that tells us, this is more likely an infection, or this one is just a pain crisis, and we need pain medicine, we need observation, but we know we're not going to have to do a surgery on this.
Right.
Those are the main things that we think about in the orthopedic world. We don't really have an increased risk of fracture. We don't have an increased risk of sprains or strains. So we don't really keep patients limited from doing the things that they would like to try and do. So I'll have families ask and say, well, can we do sports? Can we do this? And I'll say, we're only limited by what the hematologist says that they don't want to have happen for other reasons. So for example, patients with sickle cell trait who don't have the full illness have a little bit increased risk of having some issues with decreased oxygenation. And so they're maybe allowed to play football, but the athletic trainer might need to be aware that they might need increased hydration or increased oxygenation. Maybe they need some more oxygen over on the sideline because they were having some pains or aches, even though they don't have the full illness. So the hematologist will usually describe the amount of sports you're allowed to do, but from the orthopedic side, bones and joint wise, we would let anybody try anything they want. The way I look at it is you have enough issues to deal with. We shouldn't keep you limited from the things you want to try to do. So if a patient wants to run and play and do a sport, we say, well, go try it. You can figure out whether or not that's the right sport for you. If maybe it causes too much pain, maybe that's not the right thing. So maybe cross-country running might not be the sport if you've got knee pain or ankle pain or hip pain, but maybe swimming is a good sport to do. Okay. Maybe tennis is better than the repetitive pounding of track. So I let patients decide which thing that they would like to do. So sports are usually okay. We're not at increased risk of things like scoliosis or anything like that. These are mostly the repercussions of the abnormal blood cell that causes changes to the bone itself. And so most of what we do is reactive. There's not a lot of proactive things the orthopedist gets to do. So we deal with problems as they arise, and we try and ward them off by keeping the patient healthy, keeping the joints moving by using physical therapy and anticipatory guidance, trying to say, here's what you're going to run into. Call us if those things arise. So that's kind of our role. I know it's a whole lot of talking, but
it's a whole lot, but that was a whole lot.
Yep.
That was a whole lot of good information. And I just want everybody who's listening, if you have a question we're talking to Dr. Horan, and he's a pediatric orthopedic surgeon at Prisma Health Midlands. And he's talking to us today about his experience with sickle cell patients and sharing some information. So if you have a question, please put it in the comments. I wanted to touch on a couple of things, but you just about answered the question we have. It says, is AVN reversible, or are there preventative measures you can take, such as maintaining a healthy level of physical activity?
Sure. So AVN, that's the catch. It's not necessarily reversible. The older you are, the more permanent the changes are. And so I like that garden analogy because it kind of works for everything. So let's say we're growing a small plant and we catch something early and say the water was just off for a day. And we get the water right back on. And that plant's still young, so there's a lot of robust growth yet to go. Well, they might put out a new branch or a new shoot, and they keep on growing. If that's a more mature plant and it's already got fruit on it and the water gets cut off for a day or two, sometimes it can't repair itself because it's not really in the growing mode. It's more of in the maintenance mode. And so that's how an adult might be. So an adult, if they have more episodes of avascular necrosis, they don't have a lot of healing potential. So they don't have a lot of rebuilding potential, but a young child does. So if we see a patient and they're 3 or 4 years old and they already have some signs of avascular necrosis, they still have all that good growth potential yet to go. So the benefit of youth is on your side when you have those issues, because the body wants to reshape and remodel itself. So we rarely would ever do any kind of procedure on any patient who's young because the body can fix a lot of those things.
Mm-hmm.
As we get towards the age of maturity, which for girls, even though they're still young at around 14, most average girls are near skeletal maturity. So most average girls are done growing around 14, which means their bones are much more adult-like. They don't have a lot of regenerative capability. You can heal fractures and things like that, but they don't tend to fix a lot of things on their own. In the boys, that's usually closer to 16. So after around those ages, we start thinking of them as having more adult-like features. So if a child is 6 or 7 and we get a call about avascular necrosis, or we see a patient in the office for that, most of the time, our recommendation is going to be range of motion exercises to keep the joint healthy. So physical therapy. The preventative measures would be trying to keep the patient moving and active. What we don't want to see is a patient who says, well, I have this problem and I'm disabled. I can't do that. And you want to try and flip the script and say, no, I can do whatever it is that I want to try to do. So I'm able to do those things. I'm not disabled from doing those things. So I think it's important for a patient to have the right mindset about it and say, yeah, I know this is going to be sore at times, but I want to keep doing the things that I want to do. And I think if you have the right mindset, you can work around that as best you can. Now, sometimes we can't. And there's sort of the way I think of it as a bad deal of the cards. Sometimes that happens and we have a bad joint, or we have a bad bone issue that causes too much pain. What we want to do is figure out what we can do before we just take anything off the table. So healthy lifestyle in terms of being active, keeping the weight down is important. So if patients are inactive, then we tend to put on weight. The more weight we carry on our frame puts more stress on the joints, which causes more pain. And if we have anything that's abnormal, adding more problems to it is a problem. So we want our patients to keep the weight down. And we see that a lot with our patient population, is that obesity is really rampant. And you can usually tell if we look at our other members of the family and we're all overweight, we all have a lot of extra obesity in the family. Some of that's genetic. And sometimes we have to fight extra hard against our genes that want to sort of keep us storing extra fat. And unfortunately, the body almost wants to do that. We like to store things, right? Think of more of a natural thing. You know, we kind of store for the winter, if you will. But if we have extra calories and decreased activity, our body's going to store extra weight. And that is going to put extra weight on our joints and cause things to hurt. And so it's very important to stay active and to maintain a good diet to stay ahead of that, so we're in as good a shape as we can be in, so we don't have extra problems with it.
Okay. And someone just made a comment that mentioned something I already know about you.
Mm-hmm.
And she said, I appreciate the practical and optimistic approach that Dr. Horan has with his
Sure.
patients. So, yeah, that is good when you also follow up with a positive outlook with your patients.
Yeah, I think it's important. There's a lot of things, you know, everything that we see, there's ups and downs. And in the medical world, you know, there's times we get a bad draw. You think about the world when people get cancer. You know, most of the time there's not a cause for it. It's things that happen, and there's different ways to deal with it. And, you know, as we hope that people have that right attitude of, I'm going to fight this as best I can, as opposed to retreating. Unfortunately, it's very easy to become depressed and downtrodden. And I think the power of positive thinking is very important in anything we run into, whether it's a broken wrist and you miss part of your soccer season, or it's a chronic illness that you're always dealing with. I think it's important to have an ability instead of a disability. And I'll get families who come in and say, oh, we're going to start the disability process and do all this. And I get really discouraged when I hear that, because I'll get families who want to set that up for their children. And I think they're trying to be helpful just in case they have problems with work later, et cetera. But I think unfortunately, it kind of sends the wrong message sometimes of that they're different in an unfortunate way that is a disability. And I think it's better to say, boy, you're just as good as everybody else. You get out there, go run, get on that soccer field, go participate in that sport. We just might need rest. We might miss some activities, but I want you to be part of the crowd. I don't want you to be separated out because something is different about you. So I think
Right.
that's important for people to remember. They are different, but not different in a bad way. I think it's important to be optimistic.
Right. Absolutely. And we do have one other question, but I wanted
Sure.
to just mention like in the beginning when you opened up and you talked about, I've spoken to people like, why would you have an orthopedic surgeon come talk? What does that have to do with sickle cell? And so people don't under a lot of people don't understand how it impacts the entire body. And
Sure.
you explained it well when you talked about the blood flow to the bone,
Hmm.
and how sickle cell impacts that. So, and then you touched on how it's complicated, whether
Sure.
it's an infection or inflammation or for pain crisis. So it's not just black or white, or just really simple. This is something um, that impacts the entire body.
Sure, and
In
it gets hard. It's hard on our side for people that
Yeah.
see this regularly. We'll have, the hematology service may call us and say, "Oh, we've got this patient admitted with a swollen joint," and we'll think, "Uh oh, this is going to be hard to figure out." And so it gets hard for us, and sometimes it's just a clinical judgment and say, "Well, it's been 3 days. They've been on antibiotics. Not much has gotten better. Let's go put a needle in the knee to aspirate it or draw off some fluid and see if anything grows in the lab, and if it does, that might mean we need to go do something different." So even for us, it's very hard to figure those things out, and it's just another of the challenge that you have with sickle cell.
Okay. Now, where can you find AVN? I know you gave an example of the hip, but it could be where?
It could be anywhere. So ends of bones are the most common because those are the areas where you get the most effects. So for example, at the end of the femur at the knee or the top of the femur in the hip, since those are a joint and something is moving there, that's where people experience, I would say, the most symptoms. So if you think about, let's say, the knee, maybe it should be nice and level. And if we have avascular necrosis that causes some collapse of part of the joint and makes the joint not straight anymore, you're going to both feel that and see that. You can get avascular necrosis in the middle of the bone, but it usually doesn't cause a structural problem with alignment, but it causes pain. And so you'll get aches and pains that happen in the bone itself, and it's vague. So a patient might just say, it's just my thigh hurts. And it's hard to localize. You can't point at it and say it hurts right here. It's more of an achy, dull pain that might bother the entire thigh or arm or calf. The joint is easier to tell because they'll say it hurts whenever I move my hip. But
Right.
every bone can get avascular necrosis. At the joint ends is where it's most involved because it affects how the joint moves. You can get it in the fingers. You'll see it in the bones of the skull. So any bone can get it. It causes pain, but at the joint is where the actual mechanical effects are the most involved.
Okay. Dr. Horan, this question is for me.
Sure.
Have you looked into how any sickle cell treatment can maybe decrease or the rate of AVN
Mhm.
developing, like hydroxyurea or
Sure.
any of the new
Yeah.
treatments for sickle cell disease?
Yeah. So that's exactly what hydroxyurea, in the thought that, oh, hold on. I think my computer's locking up on me. You can still hear me. Great. But let me log back in because mine shut off on the screensaver, but I think you can probably still hear me.
Yes, we can
Okay,
still.
there we go. All right, just came back up. So hydroxyurea is help to try and basically help we call it the morphology or the shape of the blood cells, so it has less of the effects. The hard part is we haven't seen out there where you said, "Oh gosh, we have really noticed this big drop off in the rate of AVN." The kind of thing that the overall effects of using something like hydroxyurea do help with maybe decreased pain episodes. I think the chronic nature of the illness is what it's almost like you're under a constant barrage. It's sort of like I think about in the movies when you watch maybe a bad guy is shooting at an armored car. Maybe the armor works for a while, but since they keep shooting at it and shooting at it and shooting at it, eventually they can break through. And I think the issue that you have is because you're constantly under this duress of having these abnormal shaped blood cells, even though it helps with some of them and can decrease some of that, they're still always there. And until we have sort of a gene therapy that maybe eliminates those blood cells from being an issue, it's kind of like always getting that ammunition shooting at the car that eventually you're still going to break through and cause a problem. So even though you decrease it, that constant presence of those abnormal shaped blood cells still cause, even if it's smaller amounts of AVN, cumulatively, it still adds up. So we haven't seen on my side a big decrease in our overall incidence of AVN. But at the same time, you don't have a lot of people who really have looked to say, all right, in the last 10 years, what have I seen versus the previous 10 years? Because a lot of these treatments are still new.
Right.
But so gene therapy type of thing would be sort of that gold standard in the future, or stem cell transplants, something along those. But I have not had enough experience yet in seeing what's out there on the forefront of this compared to what your hematologist may be familiar with. So
Right.
they're going to be a lot more up on the say clinical trials for things like that than we are in our world, because we're still on the call it like the end effects of it as opposed to the forefront of it. And so your hematologist may have better answers for that in the future.
Okay. Say for example, one of you're sent a patient, a sickle cell patient who, and you're treating them because they fell off, let's say, what's the skateboard, and they
Mm-hmm.
have broken their wrist. Is there anything that you would look at a little closer when it comes to a sickle cell patient? I mean,
So
even though that's a
yep,
normal childhood
yep.
thing.
So a couple of things. So they might come in, for example, it can get overlapped with the pain that somebody might have. Remember, I was talking about those vague pains from maybe some
Mhm.
AVN. So two things about it is one, the pain tolerance can be different because a lot of our sickle cell patients have a much higher pain tolerance. So they might have an injury that somebody else might be in the ER for right away. And we might have a sickle cell patient who feels like maybe it was just a more of a bruise because it doesn't seem like it hurts as bad. So you might have that aspect where you could have a small little fracture in a place that they don't seem as bothered by because they're used to a higher level of pain. So there's that aspect that maybe somebody might miss something. I think the other thing that factors in is when we get an injury, we get increased blood flow to an area. And so let's say I have a patient who has no blood disorder, they break the wrist and they come in and they call a couple days later and say, boy, their wrist is really hurting in the cast. My thought might be, well, gosh, maybe something has moved or shifted. Let's bring them back in to check a new x-ray. I might have a sickle cell patient that might have the same complaint, and I might be less worried that something has shifted, but the increased blood flow to that area might cause an increase in the pain to that area with maybe more of that bone issue from infarctions and less likely to have a shift in the cast or something like that. So I would not be as surprised if I had a sickle cell patient who called in and something was causing more pain than in a patient with no blood disorder. And so the catch on our side is you still check everybody, but I would have a lower worry if I brought the patient back in, I checked an x-ray and I say, no, everything looks fine. This is kind of what I might expect for you, that you might have more symptoms than maybe a different wrist fracture. So you're kind of thinking a little bit like that. The catch is you don't want to just go, oh, it's from the sickle cell, they're fine, because you might miss a fracture that is moving on you. So you check everybody, but I wouldn't be as surprised if somebody has more complaints. Or let's say it's an ankle sprain, and we're like, gosh, this is weird. It just seems like it's hurting way more than you expect for an ankle sprain. Well, it could be because of that increased blood flow, and it's causing more vascular pain complaints than you might expect for an ankle sprain. So it could be all over the map. It might hurt less, it might hurt more. And so you just have to be aware that's in their medical history and sort of think through it clinically, instead of sort of a generic approach that's the same for everybody. So it's more of an a la carte thing. You just got to think about the situation, what's bothering them, and if it makes sense.
Okay. You guys, we're hearing from Dr. Horan, a pediatric orthopedic surgeon. He is giving up his time to talk to us and share with his experience and his knowledge in dealing with sickle cell patients. Um, Dr. Horan, we had a couple of comments that said, I think they were talking about your comments about being different. It's a and it's not a bad thing, not a bad
Right.
different. And she said that's awesome, not a disability, but different.
Mhm.
Um, and Brianna also said, well said when you were talking about that portion of it. So if you have any additional questions of Dr. Horan, please go ahead and put it in the chat. But if you think of one later, or those of you who are watching on the replay, add it and I will email Dr. Horan to get you an answer. But Dr. Horan, is there any other thing you want to share? You think, because our audience is, like I said earlier, is our caregivers and maybe
Mhm.
warriors themselves, and supporters who just want to know more about sickle cell disease, and how in relation to what you do. So
Sure.
is there anything else you wish to share before we?
Well, I think the main thing is just knowing, obviously, it's a complicated thing. We don't always have the right answer right away. We don't always know exactly how to predict what's going to happen. So you might hear us come in, you might talk about avascular necrosis or something else. And sometimes we can give some guesses, but as most patients are aware and caregivers are aware, it's a complicated issue. And the idea is we sort of treat the best way we know, and sometimes it's an evolving process. And so we try and come up with the best plan. Sometimes we got to change the plan, right? We don't know everything. So you might see different doctors who have different recommendations as well. So that's another thing I always point out to people is if you're seeing somebody and whatever they're saying just doesn't seem like it sits well with you, or it just leaves a funny feeling in there, I tell you this as a physician, I don't mind anybody going and talking to somebody else. That's what you should do. So let's say you're seeing one doctor and they say, we got to go do a surgery on this. You need a hip replacement. And you're like, really? My hip, it doesn't really hurt that bad. It still works pretty well. You can always do a surgery some other time, right? You can't undo one. And
Right.
so I think it's kind of like if you're having a bathroom put in your house, you don't just go with the first contractor that comes in and they say, well, it'll be a gajillion dollars. And you're like, wow, that's expensive, but okay. You call a few people and you kind of hear about it. So you'll never offend the doctor. And if it does offend them, it's not the right doctor, right? So you go get another opinion if it doesn't sound right to you, or you just want another opinion, no problem on our end. So any surgeon who doesn't want you to go get another opinion, there's something wrong with that. So just always remember that for if you have a chronic thing going on, it's okay to talk to different people about it and get different thoughts on the matter.
And I'm glad you said that. Being an advocate, a caregiver, or someone with a chronic illness, that gets difficult at times because you need your physicians because you want to be sure that, like in my case, your child is taken care of. You don't want to offend, but you saying that, and we have to remind ourselves. We have to right now, especially as caregivers, we have to be our children's advocate and
That's
voice,
right.
and get the best care, and then raise them in the process to be able to advocate for themselves. So I'm glad you said that. um,
Sure. Well, I
I'm
think it's
sure.
important because you get, you know, sometimes somebody's saying you don't need something and maybe you do. Sometimes they're saying you do need something and maybe you don't. Most of the things that we do like this, it's not a definitive science. There's scientific basis for what we do,
Mhm.
but there's still, you hear people talking about the art of medicine because it's a little bit of a clinical art of trying to figure out what's best to do, and what's best for one patient may not be the same as what's best for another. And so
Absolutely.
what you want is hopefully you have a physician that's listening to you and your needs and answers your questions. And if not, then just you go check with someone else. Even if you believe what they're saying, and that's great. It's not a big deal to get another thought on the matter. It should not hurt anybody's feelings to at least get another opinion if you want. But it doesn't mean you need one. But if
Right.
you're getting a funny feeling, just check. It's no
Yeah.
big deal.
Yeah. Sounds good to me because sometimes we got to trust that instinct, and
Yeah, the
especially.
white just the white coat isn't gospel, right? So just remember that we're all just people giving our opinions about the matter. And so especially for parents out there, it's their child they have to be aware of, and they're trying to do the best for their child. I think that involves just investigating all the avenues that you have.
Absolutely. Dr. Horan, we appreciate you, for taking time out of and I know you had a long day,
Sure.
out of your schedule to talk to us, to share. Um, share about what you've discussed with us about sickle cell disease and how it impacts the bones and the joints. So I think this is very valuable information. Again, for those who are listening on replay, leave a question in the comment, leave some positive comments, and I'll pass them on to Dr. Horan. And we will respond. But thank you again
Sure.
for talking to us. Thank you, everybody who's listening, for listening in once again. We'll be back in another 2 weeks to have another discussion. The next Tuesday chat is going to be different because I'm going to be on the opposite side. So I'm going to be the one being interviewed. So that should be different. So remember, we have a birthday bash and blood drive coming up, you guys. So we're still taking those who want to sign up to save some lives by signing up to donate blood. The link is open. It's on our page. And go ahead and register and let us know you're coming on March 26th to celebrate with us. Dr. Horan, I'm sure I will see you soon.
Well,
Great.
thank you. I appreciate it. I love what you do. I think this is great, and hopefully it was informative for folks. Happy to help.
Absolutely. All right, everybody. I bid you good night and see you next time.
Okay, bye.
Bye.